Excellent. So let's do this. Now we have to continue our today topic, which is regarding the GIT. We have not much left actually for GIT. We are almost done. And let's do it. Okay. So the alpha-1 antitrypsin deficiency, this condition, we will see it twice. The first time we are going to see it, it's now, which is in GIT. And the next time we are going to see it in pulmonology, okay? So the idea of alpha-1 antitrypsin deficiency, that there is an enzyme that is inside of the, like the liver, it's produced inside of the liver. And this enzyme help us to basically inhibit the function of something called elastase, okay? What is elastase? It's an end with an ase. Anything that ends with an ase is an enzyme, okay? So since it is an enzyme, absolutely, it's an enzyme. And most enzymes, what are they? Are they proteins, cholesterol? What are they? Yes, absolutely. So enzymes are proteins made out of amino acids. So somebody said elastase is the one from the pancreas. It's correct. The pancreas does produce elastase, but the elastase mentioned in case of alpha-1 antitrypsin deficiency is different. We are speaking about the elastase of the lung. So this elastase of the lung, well, basically, it has some function in the lung. We'll speak about it later. But he's a protein. And alpha-1 antitrypsin, it's basically also a degregative protein, which is we call a protease. So alpha-1 antitrypsin will lead basically to inhibition of the elastase. So if we say that somebody has a deficiency of this guy, the elastase is going to be super functional, which means that can lead to poor inhibition of the elastase, which will lead to multiple problems that we will see now. So let's take a look what problem we can have from that. Okay, so alpha-1 antitrypsin deficiency, misfolded gene product protein that will aggregate in the hepatocellular endoplasmic reticulum. So inside of the endoplasmic reticulum, we will have aggregation of a lot of misfolded protein. Where is that? In the hepatocellular, in the liver. Okay. So as you can see, this is a hepatocyte, and you can see all of these aggregate inside of it, which is made out of a protein. So that will keep happening for a long period of time, which can promote the cirrhosis, yeah? With BAS positive globules. As you can see in the picture here, all of the pinkish material here, it's a BAS positive material. So it's a codominant triad. A lot of people don't even know what is a codomination. So that will be my job to teach you guys what is codomination. I will tell you a few diseases that have a codomination type of thing. I'm going to start with the first disease, which is, just a second. Yes, actually not a disease, but a blood group. I want your help with this blood group thing. So please be a little bit active with this one. So I'm going to write a person here, and you can tell me which blood group is he, this guy. He's a blood group A. We don't know positive or negative. I did not make a sign. So what about this guy? It's O. Excellent. What about this guy? This is A as well, A. Okay, so let's try to understand what is codomination. Let's do it like this. If I say my father blood group was A, my mother blood group was B. So my blood group is AB. So who was dominant? Who was responsible of giving me the blood group? AB, my blood group. Was it my father or my mother? My mother and father. That's codomination. So both of the parents are responsible for transmitting the disease or the trait or whatever it is. If we say the mother is I, and the baby blood group will be, for example, let's say I and I, because it's possible to get this. If he gets this one, for example, and this one. So he's O. He's a blood group O. Is he blood group O because of his mother or because of his father? Both. It's because both of them. So this is the concept of codomination. Codomination, that means from both parents you are going to get the disease. This exists also in the case of alpha-1 antitrypsin deficiency. So let's take a look at that. It's quite rare type of disease to see that. Excellent. I was looking for this one. So take a look here. The type of genotyping is kind of different in this case. So it's not written like blood I, big I, you take one allele from each. Yes, that's correct. You take only one allele from each parent. So when we take a look here, this is an alpha-1 antitrypsin deficiency type of disease. So the mother is a carrier, so it has the healthy gene, which is the M, and the sick gene, or as I say to my student, is the sick gene, as in sick, okay? This is the sick gene. The father also has the healthy and the sick gene. So they are carriers, yeah? They might be asymptomatic or have really mild symptoms, but that's it, nothing more than that. But look at their sons. One of them has MM, which is totally healthy. MZ is carrier. ZZ, this guy is totally sick. This guy who gets the emphysema. You must know about the ZZ and MZ and this stuff. It's ridiculous, I know, but they want you to know about this type of inheritance with the Z's and the M's. They do ask about it. So let me just send you this picture. Okay. So they say, codominant trait often presents in a young patient with liver damage and dyspnea without history of tobacco smoking. So yeah, he does not smoke tobacco, but regardless, he has this really bad lung issue. Which lung issue? It's something called emphysema. Okay? So in the lungs, decrease in the alpha-1 antitrypsin, which is a protease, will lead to uninhibited elastase in the alveoles. Again, why? Well, elastase is an enzyme. So he's basically a what? Protein. Yes? And alpha-1 antitrypsin is a what? Is a protease. It's a protease. So this guy is a protease. So when he is dysfunctional, elastase activity will go up. You're like, yeah, nice. So that means the tissue becomes more elastic? The answer is no. Elastase destroy the elastic tissue. Elastase destroy the elastic tissue. So the tissue will become less elastic, and that leads to pan-acinar emphysema. I hope you know what is an emphysema. An emphysema is a disease that affects the lung, that destroy the septi or the connection between the alveoli. So let me send you. Yeah, well, there is two types. It can be in smokers, but in that case we call it centroacinar. But it can be inheritance. In case of inheritance, we call it pan-acinar. So you can see the spaces between the alveoli are super big. That's emphysema. Yep. Okay. So that is one of the main causes of emphysema. Basically, if you see liver dysfunction and lung dysfunction, think emphysema. Jaundice. Abnormal yellowing of the skin, sclera, due to bilirubin deposition. So we can have hyperbilirubinemia due to increased production or decreased clearance of the bilirubin. So the patient can have an impaired hepatic uptake or in the conjugation process which occurs inside of the liver? Well, that will be interesting. Which zone of the liver, I mean, you remember there is 3 zones of the liver. Which zone of the liver does conjugation? Nice. Yeah, so it's zone number 3. Why? Because it's the zone that contained the cytochrome B450, if you remember. So that this is zone number 3, and it had the cytochrome B450 in it. That means that this enzyme was responsible for the conjugation. Okay. So let's keep going. Yes. So they write, hot liver, common causes of increased bilirubin is hemolysis. Just write D or I, direct or indirect. Hemolysis, direct hyperbilirubinemia or indirect hyperbilirubinemia? Indirect, absolutely, because it's before the liver. What about obstruction of the bile duct? Obstruction of the bile duct. Well, obstruction of the bile duct, let me make it simple for you. If the problem is before the liver, we call it indirect, like hemolysis. If the problem is inside of the liver, we call it intrahepatic. If the problem is after the liver in the bile duct, we call it posthepatic or mechanical. For example, if it was before the liver, it will be mainly indirect. If it's in the liver, it will be both direct and indirect. If it's after the liver, it will be only direct. So if someone has a pancreatic adenocarcinoma and it's blocking the common bile duct, that will lead to mainly what elevated, direct or indirect? Direct, absolutely. Yes. Liver disease, both of them. So let's take a look. We have here conjugated, also known as direct hyperbilirubinemia. So these patients can have biliary tract obstruction due to 1, gallstones. So gallstones can lead to mechanical jaundice. Also, cholangiocarcinoma, pancreatic or liver cancers, or the liver fluke. Can somebody tell me what is this liver fluke? It has another name. Schistosomiasis, was it Manzoni or hematobium? Manzoni, it affects the liver, thus it's Manzoni. Hematobium affects the bladder. So biliary tract diseases, we have a primary sclerosing cholangitis and the primary biliary cholangitis. Don't worry about them now. They are the topic for today. Later today, we'll speak about them. And when we speak about excretion defect, also Dubain-Johnson syndrome and Rotor syndrome, we'll speak about them today as well. So the next thing we have is something about inconjugated or indirect type of hyperbilirubinemia. It can be hemolytic problem. Why hemolytic? Well, what is RBCs made out of? What do we have inside of the RBCs? Hemoglobin, absolutely. So if we have hemoglobin, hemoglobin has heme and has a globin. The heme has what? Protoporphyrin and iron. Yeah? So screw the iron. We have the protoporphyrin. The protoporphyrin can become what? What can biliverdin? Absolutely. Biliverdin. And the biliverdin can become what? Unconjugated bilirubin, absolutely. So here they mention that hemolytic anemia can lead to the hyperbilirubinemia, and now you get why. Also, physiological jaundice in babies. This is important. Which type of blood exists in the babies? I mean, when they are just born, which type of hemoglobin, I should ask? Is it hemoglobin A? Is it hemoglobin F, fetal hemoglobin, absolutely. So this would need to be destroyed, don't you think? So all of this will be destroyed, and that will lead to unconjugated hyperbilirubinemia. In addition to the enzyme that conjugate inside of the liver, which is called UDP glucuronidase transferase. In a newborn, it will be highly inactive, which lead even to more worse physiological jaundice. Physiological jaundice, is it dangerous for the baby, or it just will go away in 10 days? It will go away in 10 days. So it's important to know that it's in 10 days. Because if it is more than 10 days, you need to start suspecting other things. Here they mention two other causes of indirect hyperbilirubinemia, including Crigler-Najjar and Gilbert syndrome. Which one sounds more evil? Crigler-Najjar. So in Crigler-Najjar, we will have total absence of the UDP glucuronidase transferase. While in Gilbert syndrome, we will have only partial loss of it. That's it. So that's one of the main difference between the two. So the next thing we have is a mixed direct and indirect hyperbilirubinemia. So if it was both of them elevated, this must be intrahepatic issue, like hepatitis or cirrhosis. So the physiological neonate jaundice, let's try to understand that. At birth, lower activity of UDP glucuronidase transferase. That's the first problem. So we will have unconjugated hyperbilirubinemia, which can lead to jaundice and kernicterus. Wait for that. We also said that we have a major hemolysis because we have fetal hemoglobin, okay? The word kernicterus, icterus. What does icterus mean? Yep, but the word kernicterus comes from this guy, okay? So there is this Venezuelan bird, and he's yellow. I'm not sure about his exact name, but it's something with an ictero, so that's why they call it icterus, okay? So just keep that in mind. He's yellow. So that's why we call it icterus in the same place, kernicterus. The position of unconjugated, lipid-soluble, oh, this is important. Indirect bilirubin, also known as unconjugated bilirubin, also known as lipid-soluble bilirubin, also known as hydrophobic bilirubin. Again, I will repeat that. Unconjugated bilirubin, known as indirect bilirubin, known as lipid-soluble bilirubin, known as hydrophobic bilirubin. Okay? I hope you wrote this down. It's important to use them interchangeably. All of these mean the same. So there will be deposition of unconjugated lipid-soluble bilirubin in the brain, practically in the basal ganglia. That's why we have the kernicterus, which is what is kernicterus? Basically, they are going to develop actual motor disorders because of the deposition of the bilirubin inside of the basal ganglia. So it occurs in the first 24 hours of life and usually resolve without treatment in 1 to 2 weeks. The treatment, if you want to do it, it's phototherapy and a non-UV. So why phototherapy works? And first of all, what is phototherapy? So phototherapy is actually quite cool. Let me show you how it works. And it basically, it transforms the unconjugated bilirubin into a conjugated type of bilirubin, okay? Well, it's not actually conjugated, it's just water-soluble bilirubin. Guys, I have a question. Why do we constantly need to move the child in case of phototherapy? We need to constantly keep moving it. Notice, we need, like he's in his back, then you will have to put him on his side, then you will have to put him on the other side, never in his abdomen. It's not allowed to put a baby on his abdomen, but you need to put them, see, some of them put in on this side, see, at the same time, some of them on the other side at the same time. Why do we do that? Well, the answer is simple. When you have UV light, no, not really. You need to put it all over the body because it actually leads to the tanning of the skin, which means changes the color of the skin. So if you are going to bring a baby half-baked to his mother, she will be like, what have you done to my son? But if all of his color is symmetrical all over the place, she will be like, oh, okay. So you need to make sure it will be all over the place. Okay, so the next thing is, yeah, so it converts the unconjugated bilirubin to a water-soluble bilirubin, so it can be excreted in the urine. Yes? Okay, let me tell you a little bit about direct bilirubin. Direct bilirubin include the following. 1. Direct bilirubin is the same as saying lipid-insoluble bilirubin, which is also known as hydrophilic bilirubin, direct bilirubin, conjugated bilirubin. All of these four words stand for the same thing, direct bilirubin. Biliary atresia is the most common reason for pediatric liver transplantation. So what is the idea of biliary atresia? The biliary tract is suddenly shut, it's sealed, there is nothing. So that's quite serious because it can lead to actual really bad cirrhosis of the liver. So if you let's take a look at it, but from another region. Well, I cannot find a good picture, but basically the biliary tract is absent, okay? So it just like shut, something like this, but it's shut totally. So it cannot pass the bile down there. Okay, so that will lead to serious cirrhosis, and that might lead to you needing a liver transplant. Do we always need a liver transplant? Not if you find it early. What can you do for the patient if you find it early? Well, good thing you ask. Well, a stent will not do it. A stent will not do it. So actually there is like a procedure called the Cassay procedure, which is something like this. So I will sound like a Frankenstein for a second. See so there is no bile duct, yeah? So you have to make one. This is the stomach, this is the duodenum, this is the small intestine. So what you will do right now is something like this. You are going to cut this and take it, the small intestine, attach it to the liver, and then take the duodenum and attach it to attach it again to the alimentary tube, which is the small intestine. This is Cassay procedure, and it's used for the treatment of this condition, the biliary atresia. Okay, so fibro-obliterative destruction of the bile duct. Basically, if this is the liver and there is bile duct coming out of it, it will be fibrotic here and it will be closed, leading to cholestasis, which is going to lead to what? Which problemo is going to happen? Well, the problemo that is going to happen is inflammation, also cirrhosis of the liver, biliary cirrhosis. So often it presents as a newborn with persistent jaundice after 2 weeks of life. Darkening of the stool can occur. Darkening of the urine. The urine. Why? Because it's we said it's a hydrophilic, fat insoluble type of hyperbilirubinemia, so it will go to the urine, making the urine dark. A colic stool, because there is no stercobilinogen inside of them, because the bile is not able to reach even the stool. And hepatomegaly will be as well. Why? Because there is a backflow of bile into the liver. Also, the labs will show increase in the direct bilirubin and GGT. Why we used to use GGT as well? Can you hear me, guys? So now we have the following. We are speaking about the hereditary hyperbilirubinemia, their causes, what's up with them, and there is a few diseases you need to know about. Guys, little trick, most of the disease, not all of the disease, but most of them, I mean enzymatic related disease, are autosomal recessive. Most of them, not all of them. If you take a look here, we have Gilbert syndrome. You will have a mild decrease in the UDP glucuronidase transferase conjugation process. Can someone tell me where does this process occur in the liver? Which zone of the liver does this process occur in? One second. Let me share my screen. Can you see my screen now? Nice. Yes, it's zone 3. So asymptomatic or mild jaundice, usually with the stress, illnesses, or also fasting. So these patients are generally normal. Can you tell me stressful situation, a medically stressful situation? Of course, going to an exam is stressful, but what else? Something medically stressful for the patient. Well, I hope you are thinking about like traumas, surgery, or delivery. Okay? That's stressful. Yep, absolutely. Okay, so there will be increase in the unconjugated bilirubin, which is also known as the lipid-soluble bilirubin, hydrophobic bilirubin, indirect bilirubin, without overt hemolysis. So in this patient, their hemoglobin level will be okay. Regardless, they will have an unconjugated hyperbilirubinemia. So relatively common, it's a benign condition. The next one is something called the Crigler-Najjar syndrome. It's a type 1 type of disease. Type 1, type 2 also exists, but we will see about it in a second. So in type 1, there is 100% absent of the UDP glucuronidase transferase. So it present early with life, but some patients may not have neurological signs until later in life. Guys, do you think these patients will live without a treatment? Can they live? Yep, absolutely wrong. They die. They are 100% risk of death if you don't treat them. Okay? You must treat them. Well, how can I treat them? The treatment with the plasmapheresis, which takes the bilirubin out, also with phototherapy. You are like, wait a second, phototherapy is to get to conjugate the unconjugated bilirubin, but here it's not the deal, you know? Sorry, it's not conjugating, but turning it to a water-soluble form, yes? So, but this is not the deal. So the right phototherapy does not conjugate the unconjugated bilirubin, but does increase the polarity and increase the water solubility to allow the excretion. So again, it does not lead to increased polarity. It just it does not conjugate the bilirubin. It just increases its polarity and water solubility, thus it will go out in the urine. Okay? So liver transplant is curative, while the type 2 can respond to phenobarbital. We don't know why, but phenobarbital can induce the UDP glucuronidase transferase to work more. Okay? Which increases the liver enzymes level. Absolutely. Yes. So the phenobarbital will increase the level of the UDP glucuronidase transferase. And it only works for the type 2, not the type 1. Dubin-Johnson syndrome. So the Dubin-Johnson syndrome, I want to show you one picture that they might show you on the exam. So Dubin. So they like to show you a picture of the liver, and the liver will look something like this, which is ditch black, okay? When you see a black liver, that's it. That is the problem you are looking for, okay? So the next thing, yes, it's a conjugated type of disease, so you will have a conjugated hyperbilirubinemia, and it's due to a defective liver excretion. So they write so the main problem that yes, we conjugated, no problem with that, but we are unable to get it out of the liver. So we will have a conjugated hyperbilirubinemia. So they write it's due to an impaired excretion of epinephrine metabolite, and this disease is quite benign. So let's speak about a little bit about the difference between Dubain and Rotor. So the main difference between Dubain and Rotor, first of all, what is the similarity? Why should I even confuse them from each other? So the reason is because these two both have an increase in the direct bilirubin, while these two have both increase in the indirect bilirubin. Yeah? So the Dubin-Johnson syndrome, conjugated hyperbilirubinemia due to a defect liver excretion, grossly black, due to an impaired excretion of the epinephrine metabolite, done with that, and now phenotypically similar to Dubin-Johnson. Everything is exactly the same. The only difference, it's a little bit more milder, and the liver is normal. It's not black. Okay? So, okay. Due to an impaired hepatic storage of the conjugated bilirubin. So I just want to tell you a little bit why it's black. I know it's not like our topic for today, but I have to go a little bit back to biochem to explain this point. So if you go back to biochem, metabolism chapter, we did not do it yet. Yes. So there's this process. This patient will have a defect of this, this patient will have a defect in this guy, the DUPA decarboxylase. So they are going to get more melanin regionally. Where regionally? In the liver. If you have more melanin in the liver, which color it will be? Black. Okay? And this is basically when they were writing, it's the epinephrine metabolism pathway. This is the epinephrine metabolism pathway. And the defect in it lead to increase black liver. This is what they are meaning about. This is destroyed, so you will have more melanin, you will have a black liver. Okay. The next point is going to be concerning this graph. So first of all, this is endothelial cells inside of the vessel. The hemoglobin become a circulating bilirubin. It will be albumin bound. It's an unconjugated water insoluble type of bilirubin. So it's water insoluble is the same as saying fat soluble, which means it can make it to the brain and lead to kernicterus. Kupffer cells, the macrophages of the liver, you remember these guys, and here we will pass the space of this C where the stellate cells used to sit, and then we will have bilirubin uptake by the hepatocytes as an unconjugated bilirubin. Then the UDP-glucuronidase transferase is working, making it conjugated bilirubin. Remember, two diseases were here, Gilbert syndrome and the Crigler-Najjar. When you get a conjugated bilirubin, now you have to excrete it outside of the liver using the bile flow. So in Dubain and Drotar, that was the problem, the excretion outside of the liver. Okay? So, yep. Now we speak about Wilson disease and hemochromatosis. Both of these diseases are going to lead to some form of cirrhosis in the liver. That's why we are going to discuss them now. But what I want you to know before explaining anything in these, that one of them is curable by hepatic transplantation and the other one is not. So what do you think? Which one is curable by hepatic transplantation? The answer is Wilson disease. I will explain why. So basically, imagine this as a portion of your intestine, okay? And imagine this as the excretory ductules outside of your liver. Okay. So now we have the following. If we speak about a disease such as hemochromatosis, if you enlarge here, there will be a cell called enterocyte, okay? This enterocyte has something in it called ferroportin. The function of ferroportin is to get the iron inside of your body. In case of hemochromatosis, this ferroportin is working excessively, yeah? So it gets plenty of iron inside of your body. When you get a lot of iron inside of the liver, that is going to become a free radical using something called Fenton reaction. So this free radical is going to lead to cirrhosis of the liver. So if you are removing the liver and putting in a new one, will the disease happen again? Think about it logically. Yes, because the problem is in the intestine. It's not in the liver. So the disease will happen again. But if the patient has Wilson disease, the problem with the Wilson disease that they reabsorb copper normally like any other human being, but the problem with the copper that after they get it inside of the body, they cannot excrete it outside. That's the problem, okay? So when you change the liver, you are going to change the liver and the biliary tract. Basically, patient with Wilson disease have problem in the excretion of the copper using the liver. So if you change the liver, you will be able to excrete the copper. Is that curable for Wilson? Absolutely, yes. Okay, so that makes sense. We can now start reading. Wilson disease, also known as hepato, which is liver, lenticular, which is the lens inside of the brain. You are like, no, the lens inside of the eye. No, the lens is inside of the brain. Let me explain. So inside of the brain, there is a structure called the basal ganglia. These guys. Can you see these guys? These are the basal ganglia. They are basically gray matter located within the brain, okay? And this gray matter is made up of the cell bodies of the neurons. As you can see here, it's written lentiform nucleus. The lentiform nucleus is made up of the putamen, globus pallidus internus and externus. Together, they make a lens-like structure. This lens-like structure, which is this one, is called the lentiform nucleus, and it's affected by Wilson disease. So that's why we call it hepatolenticular degeneration. So there will be degeneration of the liver and the problemo in the lentiform nucleus in the brain. So already you can think that Wilson disease will have neurological symptoms. Autosomal recessive mutation in hepatocyte copper transporting ATPase, which is the ATP7B gene on the chromosome 13. They decrease the copper incorporation into the ceruloplasmin and the excretion into the bile, which decrease the serum ceruloplasmin. Well, what does that mean? Well, basically, it's impossible here to excrete the copper outside of the body. That lead to accumulation of the copper inside of the body. If you have a lot of copper inside of the body, the transporter of copper inside of the body, which is ceruloplasmin, will it be high or low? What? No, it will be really low. You already have so much copper in your body. Should you move it around? The answer, you should not. Well, basically, when do you use ceruloplasmin? When the copper is really low and you need to get more, you know? But if you already have a massive amount, the ceruloplasmin is going to go down, okay? So the copper will accumulate, especially in the liver and the brain, in the basal ganglia, in the lentiform nucleus, as we saw, and in the cornea, and in the kidneys. And that will increase the urine copper. So let's take a look actually about the cornea, because it's a typical USMLE question. So there is something called the Kaiser-Fisher link. Be careful. Here it has which color? Brown. And is this the same? This one is a green. Why it's a green? It does not make sense. Well, I can see a green one and I can see a brown one. Why this one is brown and why this one is green? The green one is oxidized. I will give you a memory hook that you will never forget. Statue of Liberty. Well, Statue of Liberty is green, correct? Does anybody know what is the Statue of Liberty made out of? It's actually made out of copper. It's made out of copper, okay? So you can see this is the real color of the Statue of Liberty, okay? And after so many years, oxidation has happened and now it becomes greenish, okay? So that's interesting. Nice. Okay, the patient can also have kidney dysfunction and increase in the urine cover. It presents before age 40 with liver disease like hepatitis, acute liver failure, and cirrhosis. Keep in mind, all of the liver problems are due to free radical injury due to the Fenton reaction. Neurological disease such as, because of the basal ganglia, of course, dysarthria, dystonia, tremor, and Parkinsonism can occur. Does anybody know what does dysarthria mean? That's what dysarthria mean. Okay? It's basically problem with the pronunciation and speaking. Dystonia, does anybody know what dystonia mean? Well, dystonia has multiple cases, and there is one I wanna show you. One of them, if you know, like wrestling, there is this Undertaker. He has this eye movement, oculogyric crisis, or to be stuck in one movement. For example, torticollis, yeah? Or oculogyric crisis. We have something called oculogyric crisis, something like this. Yep. Okay. So psychiatric disease can happen as well. Kaiser-Fleischer ring. So there will be deposit inside of the descendant membrane of the cornea, which is the lowest layer of the cornea. Hemolytic anemia, renal disease like Fanconi syndrome can occur at the most. Does anybody remember at which tubule do we have Fanconi syndrome? The proximal convoluted tubule, absolutely. The treatment of this disease is with a Benny. Does anybody remember what is a Benny in the US made out of? Benny. Yep, absolutely correct. A Benny in the US is made out of copper. Good. So we use penicillin, to treat Wilson disease. So it's not enough to use one Benny. You have to use 3 Bennies. So 3-entine or penicillamine can be used to treat Wilson disease. What about this oral zinc? Well, guys, the oral zinc, you need to know the mechanism, actually. It's not mentioned here, but you need to know it, so write it down. The zinc and the copper are absorbed from the intestine by the same receptor, by the same pump. What does that mean? Well, that basically means that if you give so much zinc, will you be able to reabsorb copper? Yes or no? Nope, absolutely. Good. So liver transplant and acute liver failure related to Wilson disease is actually curative. Now we speak about the hemochromatosis. It's also autosomal recessive, a mutation in the HFE gene, which is located on the chromosome 6. It leads to an abnormal iron sensing and increase in the intestinal absorption. Okay, if we have a ridiculous amount of absorption from the intestine, and as you can see, the problem in case of hemochromatosis is an absorptive problem. It's a problem in the absorption from the intestine. So even if you decide to change the liver, you will still have the same problem, okay? So the next thing we have here is like increased intestinal absorption. which lead to increase in the iron and increase in the ferritin. Okay, if we have so much iron, what will happen to the guy who transport iron and bring you more iron? He should go down. He should go down. Guys, when you have so much of it, when you have so much iron, you should not get more iron from the deposit. No need. So your transferrin should go down, because if it's up, that means he's bringing you more iron. You already have plenty. So the TIBC, which represents the transferrin basically, will go down. But the saturation of that little amount of transferrin that you will have, it will be high. So why? Because yeah, I have a little bit of a transferrin, but I have so much iron, so it will be totally saturated. Iron overload can also be secondary to chronic transfusion therapy. This is, we call it secondary hemochromatosis, such as in patients with beta thalassemia major. So we keep giving them injections with the transfusions basically, and they can get a lot of outside iron, which lead them to get this secondary hemochromatosis. Iron accumulates, especially in the liver, pancreas, that will lead to diabetes, skin, lead to darkening of the skin, heart, lead to both restrictive and dilated cardiomyopathy, pituitary, joints, lead to joint pain, and hemosiderin, which is an iron, can be identified in the liver MRI or biopsy with a Prussian blue stain, which looks something like this. Remember, Russians are made out of iron. So Russian is going to be iron. Okay? Now I have a question actually. Do you remember a condition called lipofuscin? Or lipofuscin if you want. Some people say like that. Doesn't matter. Lipofuscin, how can I differentiate it from hemochromatosis inside of the histology? So if you take a look here, this is hemochromatosis of the heart. If you take a look here, this is a lipofuscin of the heart. Guys, I swear to God, it looks exactly the same. So how can I differentiate between them? The answer is by the age of the patient. Lipofuscin patient will be more than 70. Hemochromatosis patient will be 40. Okay? Keep that in mind. You need to know the age of the patient, and according to the age of the patient, you will decide, is this lipofuscin or is it hemochromatosis? So old patient will have lipofuscin. Young patient will have hemochromatosis. It presents after the age of 40 when the total body iron is around more than 20 grams. Iron loss through menstruation slows the progression in females, so they will have later presentation. Classical triad includes cirrhosis because it accumulates in the liver, diabetes mellitus because it accumulates in the pancreas. Skin pigmentation, which is also known as bronze diabetes, also can lead to restrictive or dilated cardiomyopathy, and also hypogonadism because it accumulates inside of the testicles. Arthropathy, especially leading to something called the pseudogout. Okay? So pseudogout, make a note about that. Pseudogout will have calcium pyrophosphate deposition in it. It's a condition we'll speak about in MSK, especially in the metacarpopharyngeal joint of the hand. Hepatocellular carcinoma is a common cause of death in these patients. So how do you solve it? Repeated phlebotomy, iron chelation with all of the ferro one. Notice, ferri. So anything with an Fe, because remember the chemical element of the iron is Fe. Yes? Okay, notice again, the transplantation works in Wilson disease, but it does not work in case of hemochromatosis. Okay, so let's speak a little bit about biliary tract disease, and yeah. So biliary tract disease, it may present with a pruritus, which is itchiness, jaundice and dark urine, light colored stool as well, and hepatosplenomegaly. So, okay, what's up with this disease? It's typically have a cholestatic pattern on the LFTs, which is the liver function test, in which the patient will have plenty of conjugated bilirubin, cholesterol, and increase in the ALB and GGT. Well, guys, this is important. ALB versus GGT. Which one is more specific for the biliary tract between these two? No, ALB can be also in which other tissue? ALB, not really, not in the heart. Maybe in the heart, but it's not the main one. Actually, the main one is the bone. Remember, so alkaline phosphatase is also possible to have it inside of the bone. That's important. Okay, so let's speak about the next thing. We have primary sclerosing cholangitis, unknown cause of concentric onion skin bile duct fibrosis, alternating stricture and dilatation with beading of intra and extra hepatic bile duct on ARCB. You are like, what is that? Well, this disease, primary sclerosing cholangitis, it's a genetic disease, okay? So the patient gets it. We don't know exactly why. It's idiopathic type of thing. It's probably congenital, but we are not 100% sure. So this patient on histology, you will see this onion scale peeling of their bile duct, okay? And they have this, if we say that this is the bile duct, they will have something like this. So constriction, no constriction, constriction, no constriction, and like that, it keeps going. So let's take a look what does it look like. So we are going to speak about the primary sclerosing cholangitis. Yeah, if you remember, do you remember which vasculitis actually had these beads on the string? Polyarteritis nodosa had it in the kidney, and Kawasaki had it in the coronary artery. Yeah? So this is the beads on the string type of thing, but actually they are not that nice. Thus, they will show you this picture, okay? It's in the like ERCB testing. Remember, what is ERCB? It is endoscopic retrograde cholangiopancreatography, okay? Which is like they go through the mouth to the esophagus, to the stomach, to the duodenum. Then they put a little like needle here and they push contrast and they can see this thing. Okay. So yeah, now it makes sense what is bleeding, and it can occur for both intra and extra hepatic vessels. Okay. Okay. So magnetic resonance cholangiopancreatography also can be done, which is also known as MRCB. MRCB. Here it is. Okay. So classically in the middle-aged males with ulcerative colitis. Why ulcerative colitis is a huge association? The reason that we have a huge association with it is because it's a P-ANCA disease. And you remember that ulcerative colitis was a P-ANCA associated. So it's associated with ulcerative colitis because it's a P-ANCA, as you can see. The patient will have an increase in IgM, and it can lead to secondary biliary cirrhosis, which is this guy. Increased risk of cholangiocarcinoma and gallbladder cancer. Please know about the cancer. They do ask about this. They want you to know the category of patient that it happens in. It's men, okay? Why they like to know about this? Because, guys, is it typical for men to have such disease? I mean autoimmune diseases? No, it's mostly the autoimmune disease are mostly in women, okay? So the next disease is in the babe. Why I'm calling her the babe? Well, primary sclerosing cholangitis and the primary biliary cholangitis. I mean, I swear to God, the naming themselves are really confusing. The only difference here that this one is sclerosing and the only one here is a B, okay? So make something with the S to relate it with boys. I don't know what you can think about. And the B makes something to relate it with girls. I just say B for babe, okay? And the S for whatever you want. So the B for babe, which is a lady. So it's a middle-aged female. Autoimmune reaction, lymphocytic infiltration, and they might have granulomas, okay? It's mostly affect inside of the liver, while men, well, sclerosing, it affected both inside and outside of the liver, intra and extrahepatic. This one will be only intrahepatic, okay? Make a note about this. So this, intra and extra. This, only intra. So primary biliary cholangitis, classically in a middle-aged female. Guys, who gave us mitochondria, mom or dad? Mother. The mother. So yeah, classically a middle-aged female, so the females will have this anti-mitochondrial antibody, just like a memory hook. Also, they have increased IgM. It's associated with other autoimmune conditions, of course, like Hashimoto thyroiditis, rheumatic arthritis, or celiac disease. The treatment is with orcidiol, which basically help to dissolve any formation of any form of stones. Also, it helped to clear out the bile from the liver. So secondary biliary cirrhosis, it's an extrahepatic biliary obstruction. And keep in mind, please, that the idea is like this before I say anything. So this is the liver, and it has this bile ducts coming out of it, yes? So if you block this, the bile cannot go down, so it will go up. If it goes up, it's going to fill the liver. So if it fills the liver, what will happen to it? Cirrhosis, okay? So they write, extrahepatic biliary obstruction can increase the pressure in the intrahepatic duct, which can lead to basically to fibrosis and injury and bile stasis of the liver himself. Patients are known with an obstructive lesion like gallstones, biliary stricture, or pancreatic carcinoma. Doesn't really matter. Anything that will block the outflow of the liver. It might be complicated by an acute cholangitis, okay? It can be complicated by an acute cholangitis. So let's speak about cholelithiasis and related pathologies. So what's up with this thing? Cholelithiasis. So cholelithiasis is, what does the word lithos in Latin mean? Lithos. Any ideas? Stone. So cholelithiasis, it's like gallstones and related pathology. Let's take a look. So first of all, we need to know what is a stone, what is bile made out of? Bile has many things. It has bilirubin in it, it has cholesterol in it, it has bile acids in it. So take a look. They write, increase in the cholesterol or bilirubin, decrease in the bile acids, and gallbladder stasis are all causes of stones. So if you have so much cholesterol, you are going to get hypersaturation of the cholesterol, and you are going to get a cholesterol stone, okay? If you are going to get a lot of bilirubin, you are going to get hypersaturation of the bilirubin, and you are going to get pigmented stones, okay? So also decrease in the bile salts, which increase the other substances, which also lead to stone, or also stasis when the gallbladder does not move a lot. Two types of stone: cholesterol stone, pigmented stone. Starting with the cholesterol stone. It's radiolucent, 10 to 20% can be opaque, because if they calcify. It's mostly associated with obesity or Crohn's disease, okay? So also advanced age can precipitate to it, and also estrogen therapy, we will see why in a sec, and multibarity, rapid weight loss as well, and medication like fibrate. We'll speak about each of these. Let's start with the Crohn's disease. Well, if someone has a Crohn's disease, which portion of his intestine will be destroyed the most? Which portion of the intestine is highly susceptible to injury in case of a Crohn's disease? The answer is ileum. Absolutely, ileum. The ileum used to reabsorb bile salts. can it reabsorb bile salt after its destruction by Crohn's disease? The answer is no. If you cannot reabsorb it, you are going to have hypersaturation with cholesterol, for example, or actually bilirubin. It can be either. So if it is cholesterol, it's going to be cholesterol stone. If it was bilirubin, it will be a pigmented stones. End of the story. So the main problem that you have caused is the decrease in the bile salts because of the decrease of the enterohepatic circulation, which is the movement of the bile salts from the intestine to the liver. Okay. Okay, so also they are mentioning here fibrate. Why fibrate? Because it leads to inhibition of this enzyme, 7-alpha hydroxylase. Okay, so they write here. Pigmented stones, also known as a black stones, like this guy. Can you see it? It's a black stone. So this black stone, it's a radiobic always, which is a good sign actually. So it's calcium bilirubinate related, and most likely it's because of hemolysis. Can you tell me any condition that can lead to hemolysis? I mean chronic hemolysis? G6PD, good. What else? I hope you are thinking spherocytosis, thalassemia, G6PD, all of this stuff, all of the hemolytic disease, absolutely. So hemolysis, so far we have the black stones, this because of the hemolysis. The brown one are radiolucent, not radiooblique, and they are because of infection. There is association with the Crohn's disease. Why? Because we have decrease in the bile salts, which increase the other substances which can lead to the stone formation. Chronic hemolysis, alcoholic cirrhosis, or advanced age biliary infection, the brown stones, or total parenteral therapy. Nutrition. These people who gets like an IV tube that they get fed from it. So if they are fed by a tube, will the gallbladder be contracting? I mean, the cholecystokinin, will it be secreted if they are fed by a tube? The answer is no. So if the cholecystokinin is not secreted, will the gallbladder contract? No. So they get stones. Okay. Risk factors: female, fat, fertile, and 40. Yep. The most common complication is cholecystitis. Can also lead to acute pancreatitis. Why? Well, let's continue drawing this. If you keep going down, we have this confluence, and here we have the ampulla of Vatar, if you remember. So if the stone comes here and it travels and obstructs the ampulla of Vatar right here, and the pancreatic juice goes back, that will lead to pancreatitis. Okay? So it can lead to cholecystitis or pancreatitis. Acute cholangitis, diagnose it with an ultrasound, treat it with an elective cholecystectomy if symptomatic. So you can see here chronic hemolysis, biliary tract infection will lead to unconjugated bilirubin, increase in the unconjugated bilirubin, leading to gallbladder stasis. Okay? So if the patient also have either increase in the unconjugated bilirubin or have a gallbladder stasis due to many causes, for example, the one we just spoke about, guys, which is total parenteral therapy, that will lead to suprasaturation of bile with calcium bilirubinate, which will lead to pigmented stones, which can be black or brown. Brown in case of infection, black in case of hemolysis. Sex, which is female, obesity, and age more than 40, genetics, like all of my family got gallstones, I got it as well. Decreased cholesterol, 7-alpha hydroxylase because of fibrate, for example. Fibrate, for example. All of this will lead to hypersaturation of the cholesterol here and decrease in the bile salts, which can lead to gallbladder stasis. Also gallbladder stasis. This will lead to suprasaturation of the cholesterol this time, and that will lead to cholesterol stones, which you can see here. The treatment is cut it and take it out, or try to remove the stone with ERCP. Okay? Is there any medication we can use to take the stone out? I mean, like cholesterol stone out? The answer actually there is, which is like this guy, you can use it, which is the orcidiol, but we don't. Why? it's much cheaper for the patient to get the surgery, and for us as well. You can melt it, but it takes like 2-3 years to do so, and the medication is actually expensive, and we are kind of afraid from them. Why? Because if you had a big stone like this, can it get out from the gallbladder? It cannot. So can it lead to jaundice? Yes or no? It cannot. It cannot. Why it can lead to jaundice if it's not exiting? It's not blocking the flow. Even if you had a stone in the cystic duct, it will not lead to jaundice. It's not obstructing the flow. You only get the jaundice when the stone is blocking this area. Okay? So, let's say you give the ursidiol and the stone becomes much more smaller. Can it now pass to the common bile duct? When we make it smaller? Yes. So that means we are making more risk of obstruction by making it smaller? Is there more? Yes, absolutely. So there will be more risk of obstruction if we make it smaller by ursidiol. Thus, it's inefficient. Guys, back in time, surgeons used to treat 2 diseases all the time, which were cholelithiasis and gastric ulcer. That was their 24-hour job. Even go to any surgery department. 70% of all of the surgeries they do are cholelithiasis. That's everything they do. Okay, back in the time used to be like, most of it was gastric ulcer. But we, internists, took it away from them. Why? Because of the triple therapy. Since we have discovered the treatment for the H. pylori, the numbers of ulcers started to eradicate. I mean, we can treat the ulcers with medication, so the surgical intervention was not needed anymore. So from then, the number of surgical patients with an ulcer, gastric ulcer, has decreased significantly. But these guys, the surgeon, still control the cholelithiasis, not the internist. It's not our job. So, biliary colic. It's associated with nausea, vomiting, and dull right upper quadrant pain. So what is the idea? Let's take a look. This is the cystic duct. This is the gallbladder. We have a stone. It's blocking here. Yes? Okay, I ate fatty meal. Okay? The fatty meal made it inside of my duodenum. Which hormone will be released? Absolutely, yes, CCK, cholecystokinin. So when my duodenum senses the increase of cholesterol inside of it, he will start releasing cholecystokinin. When the cholecystokinin will be high, we will have what will happen to the, the gallbladder? Contract, yes. And when it contracts against this blockage, what will happen to the patient? The answer is pain. Okay? So they're right. Neurohormonal activation by CCK after a fatty meal, it triggers contraction of the gallbladder, forcing the stone into the cystic duct, which is quite painful. So because the flow of the bile did not get affected, it's still flowing. Will it lead to jaundice? I mean, a biliary colic. Will it lead to jaundice? The stone is here. Absolutely no jaundice, just pain. So even the labs will be okay, no increase in the bilirubin, but the ultrasound will show you the stones inside of the gallbladder. Now, cholelithiasis. So now the stone is in a different place. The stone is here. So tell me, please, if the stone is here in the common bile duct, will we have jaundice? Okay. Will we have increased bilirubin? Yep. Okay, so there will be gallstones in the common bile duct, often leading to elevated ALB and GGT. Which one is specific for the biliary tract? GGT, absolutely. And they're right, direct hyperbilirubinemia will occur. And sometimes, if it lasts for a long time, it will go and there will be reflux of the bile to the liver, which is going to lead to high ALT and AST. The next disease is cholecystitis, which is an acute or chronic inflammation of the gallbladder. So, calliculus cholecystitis, acalliculus cholecystitis, and gallstone ileus. These are the diseases we'll speak about right now. So the cholecystitis can be either acute or chronic. So we have the first one with the stones, calliculus cholecystitis, most common type, due to gallstones impaction in the cystic duct resulting in an inflammation and gallbladder wall thickening, which can lead to secondary infection. Now you need to know how does the ultrasound of the gallstones look like, and you need to be able to diagnose it from the ultrasound. Let's take a look. Let's try to understand what is an ultrasound, how do we do the test, and what does it even mean. Okay, so first of all, the ultrasound machine, it's put in here. Yes, this is the probe, and you are looking like this. Okay, so this is the gallbladder, this is the stone, this is behind the stones, it's the shadow of the stone. Yes, and here you can see something. I mean, this is the stone, we established that, but there is something here which is a sludge. Okay, it's a sludge, it's like a mucus like structure which is going to form more stones soon. So yeah, also if I go really close and you measure the distance between here and here, it will be white, which means that this is inflammation of the wall. Okay, thick, yes, inflammation of the wall. So they say calliculus cholecystitis, most common type, due to gallstone impaction in the cystic duct resulting in inflammation and gallbladder wall thickness, and it can produce secondary infection. Okay. The next one is acalculous cholecystitis. So there is no stone, but the patient still get inflammation of the gallbladder. How come? So it's because the bladder is not infected, the gallbladder is not moving, stasis. Okay, or hypoperfusion. Well, which is, or infection by CMV, like in a transplant patient. So all of these can happen in whom? Patient who is critically ill, and this is an ICU favorite. The patient in the intensive care unit, they will have gallbladder stasis. Why? Because most of their nutrition is IV. Yes, they don't have a working system. If they had massive bleeding, they will have hypoperfusion, and they are at risk of infection because most of them, their immune system is messed up. Now they speak about Murphy sign. What is this Murphy sign? Basically, you tell the patient to exhale. So when I exhale, what will happen to my liver? Will it go up or down? Let's imagine. I inhale, my liver goes down. I exhale, my liver goes up. Yes? Good. Inhale, exhale. Got it? So, well, you will tell the patient, can you please exhale? And he will exhale. So, his liver goes up with the gallbladder, of course. Now you put your hand here, okay? Tell him to inhale. Now he inhales. The liver goes down. His gallbladder is going to touch your hand. So it's painful or painless when it touches your hand if it's inflamed. It's painful. So he will halt his breathing. He will suddenly be like, he will stop breathing. So that's a positive Murphy sign. Inspiratory arrest on the right upper quadrant, palpation due to the pain. Pain might go to the shoulder. Why? Because sometimes there will be irritation of the phrenic nerve. Please, you must know where the phrenic nerve comes from. The answer is C3, C4, C5. Keep the diaphragm alive. Okay, so C3, C4, C5. Keep the diaphragm alive. So there will be increase in the ALB if the bile ducts become involved. That's in a cases of acute cholangitis. Okay, so diagnosis with an ultrasound or cholecystography, which is a HIDA scan. Okay, so what is a HIDA scan? It's basically some form of a contrast. We give it to the patient. It's going to go from the liver down to the bile ductules, and it's going to go literally everywhere inside of the biliary tract. So if there is any obstruction, it will be revealed. It's a nuclear medicine test. So the next thing is a gallstone ileus. What is the idea? Well, let me try to become an artist for a second. So if we say that this is the liver, well, okay, I'm not a good artist, so, and that will take time, so I'm just going to show you a picture. So take a look. This is the gallbladder. If it will be constantly inflamed for a really long period of time, there is going to be an adhesion here, okay? So this adhesion is going to create a fistula between the gallbladder and the duodenum. Why does the fistula occur? Because of chronic inflammation, okay? Chronic inflammation will lead to a hole between these two hollow organs. And if there is a stone here, it can pass and fall here. Good, it falls here. Where do you think it will get stuck? What is the narrowest portion of your small intestine? Well, I hope you are thinking about the narrowest portion of your small intestine. That is exactly the last portion of the ileum, which is the ileocecal valve, okay? So they write, fistula between the gallbladder and the GI tract. The stone will enter the GI lumen and it can obstruct the ileocecal valve, which is the narrowest point, which is the connection between the ileum and the cecum, yes? So it can see, oh, yeah, I will show you this. One of the signs that you will be able to see air inside of the biliary tree, which is known as pneumonobila. So let's take a look at that. So there will be air inside of the biliary tract. As you can see here, these little black spots are air. Normally you should have zero air inside of your biliary tract. So if you get any air there, that means this patient has some connection with the intestine, which is basically a fistula, yeah? So you can take a look at this guy. Yes, okay, that's what I was looking for. Can you see this haziness? This is air. Air should not be there. Should not be near the liver. Okay. Guys, one of you is not muted. Okay. So let's keep going. Nice. Let's keep going. Well, the next point is regular triad. Radiographic finding of pneumonobila, small bowel obstruction, and gallstone, usually in the right iliac fossa, which will be causing colicky pain. Yes, because of the obstruction. Okay, so now we take a little break. We come back after the break and we finish the pathology of the GIT. We only have 1.5 page left. If we will have some time, hopefully I will be able to finish this as well. So see you guys in 10 minutes. Let me just start this. Okay, so for porcelain gallbladder, you must remove it immediately, and it looks like this. There is a whitish rim around it, and when it's seen, it's a risk of like cancer of the gallbladder, which is really lethal, and you need to remove it immediately. So they write calcified gallbladder due to chronic cholecystitis, usually found incidentally on imaging, as you can see here. And the treatment, prophylactic cholecystectomy, generally recommended because these patients have an increased risk of gallbladder cancer, mostly adenocarcinoma. What is the prognosis of a patient with an adenocarcinoma of the gallbladder? Is it good or bad, the prognosis? It's really bad. So, guys, one of the worst cancer a human being can get is actually the gallbladder cancers and the pancreatic cancer. These two just really suck. It's really difficult to monitor them, to deal with them, and the prognosis is just really bad, okay? So, the next point I'm going to speak about is this one. Let's take a look. We have something about acute cholecystitis, also called ascending cholangiitis. So infection of the biliary tree usually due to an obstruction that lead to stasis or bacterial overflow. Let's try to understand this. Cholangitis, angio. What does angio mean? Vessel. Angio means a vessel. Which vessel do we have? Well, we have arteries, we have vein, and we have bile ducts. So all of these three are considered as vessels. It's kind of interesting because a lot of students think that bile ducts are not vessels. They are. Bile ducts are vessels. So ascending cholangitis, it's an inflammation of the bile ductules. It's an ascending type of inflammation. So it can lead to horrible infection of the biliary tree that is going up, and that can lead to bacterial overgrowth and stasis. Which type of stone it might lead to? What do you think? Which type of stone can a biliary infection lead to? Brown stone, absolutely correct. So acute cholangitis can lead to the Charcot triad, which is including the following. So this is the triad. We'll have, the patient will have jaundice, will have fever, and right upper quadrant pain. Now I have a question. In case of cholecystitis, not acute cholangitis, in case of cholecystitis, was the Murphy sign positive on inspiration or expiration? The Murphy sign. Inspiration. Remember, the liver goes down, hit your hand, it's painful. Okay. Renoid Bentad is a Charcot triad plus altered mental status and shock. That will lead to, in case of shock, basically you can identify shock by hypertension. Cholangiosarcoma, it's a really bad cancer also. It's a malignant tumor of the bile duct epithelium. Risk factor include primary sclerosing cholangitis. Remember, was this disease in men or in ladies? Sclerosing was in men. Yep. So, yeah, liver fluke like schistosoma, Manzoni or hematobium. What do you think? Manzoni. Yep. And also they say other causes usually presents late with fatigue, weight loss, and abdominal pain and jaundice. Basically non-specific signs. So it may show biliary tract obstruction as well, which will increase the direct bilirubin. The histology will show an infiltrating neoplastic glands associated with a desmoblastic stroma. Let's take a look at that. So cholangiocarcinoma. Just a momento. Yes, okay, this is a good one. Okay. So this little slit is actually the opening of the bile ductules. But as you can see, it's ridiculously huge. It's just like massive. And in this patient, when you take a look at the histology of them, you can see an increase of the nuclear to cytoplasmatic ratio. So that's actually a bad sign. And you can see that they have so much deposition of material between the cells, okay? So high nuclear to cytoplasmatic ratio and a humongous deposition between the cells. Okay. Acute pancreatitis versus chronic pancreatitis versus pancreatic adenocarcinoma. Let's start with acute pancreatitis. Is it fatal? Yes or no? Acute pancreatitis. Mostly yes. So acute pancreatitis can lead to autodigestion by pancreatic enzymes inside of the liver, inside of the pancreas. Which enzyme does the pancreas produce? The answer is many. We have lipase, we have amylase, we have elastase, we have trypsin, we have chymotrypsin, we have so many. So it can lead to autodigestion of the pancreas by the pancreatic enzyme. And you need to know the CT finding of it. By the way, guys, make a little note. Gallbladder, what is the best test for it? The answer is, somebody write it, please. So for gallbladder, it's USG, that's correct. For the pancreas, it's what? CT. What about for the appendix? This is a tricky one. What is the best test for appendix? So here is the thing. We do USG, but the best test, the gold standard, is actually a CT. Okay? So the gold standard is CT, but actually in the clinic we do USG because it's less expensive, less invasive. Okay, so let's take a look at this guy. As you can see here in this area, yeah, this is the edema basically of the patient. This is like, you can see something here. This is the edema. Okay? So this is a sign of acute pancreatitis. So they write, the causes of it, I get smashed. Idiopathic, we don't know why. Gallstones, because that will reverse the pancreatic juice back to the liver. Ethanol, trauma, steroids, mumps virus. The other problems that mumps can lead to: parotitis, inflammation of the parotid gland, meningitis, and orchitis, inflammation of the testicles. It's an autoimmune disease. Autoimmune disease can also lead to acute pancreatitis. Scorpion sting. Okay, keep that in mind. Scorpion sting is kind of rare, so they like rare stuff, especially the blonde one. And hypercalcemia and hypertriglyceridemia, especially if it was more than 1,000. We will learn in biochemistry about dyslipidemias, especially type 1 and type 3. They can lead to a hypertriglyceridemia more than 1,000, which can precipitate to acute pancreatitis. Okay? Also ERCP. Why? Well, during the ERCP process, we used to go from the mouth, ERCP, from the mouth to the esophagus, to the stomach, to the gallbladder, to the biliary tract, and put a little tube inside. See, you can even inflate a balloon and pull it to take it out. And yeah, so it was a really, really invasive procedure. And there is something here. This sphincter of Uddi is a bitch. If you touch him, he constricts. He's like the anal sphincter. The moment you touch it, it constricts. Whoa. Can you hear me now? Okay. So the next thing we have, the drugs that can lead to pancreatitis include the sulfa drugs, the anti-HIV drug, the NRTIs, and the protease inhibitor. So they like especially the adenosine. Okay, that's the NRTI that mostly can lead to pancreatitis. So they say the diagnosis can be done by 2 of 3 criteria. So you need to have an acute epigastric pain, preferably radiating to the back. High amount of amylase or lipase. Why lipase is more specific than amylase, please? Amylase exists also in the saliva, absolutely correct. So up to 3 times the upper limit of normal, or characteristic imaging finding like the edema around the pancreas. Complications that can occur in this patient include the pseudocyst. If you take a look at this picture, see this little thing? This is the pancreas. See this horrible big thing? This is the pseudocyst. Well, why it's called a pseudocyst? Because normally cysts has epithelial cells around it. Okay? So the epithelial cells make the walls of the cyst. But the pseudocyst, on the other hand, you will have a granulation tissue making the wall. Granulation tissue. So we say pseudocyst, not an actual cyst. Also, complication of acute pancreatitis can include abscess or necrosis. Also, hemorrhage, infection, or organ failure. So this patient can have acute lung injury or ARDS. Why? Because there is an enzyme called the trypsin, And it's actually the cause of the acute pancreatitis because the trypsinogen becomes a trypsin early on. It should become a trypsin where? Where it should become a trypsin normally? In the duodenum. With the help of which enzyme? Come on. Which enzyme help us to make the trypsin out of the trypsinogen? Well, there is an enzyme located in the duodenum wall, also known as the brush border enzyme. Any ideas, guys? Brush border enzyme. It has two names. No? Okay, so we have this brush border enzyme. It's called peptidokinase, and there is one more name of it, which is, let me actually make sure. They do ask this a lot, so that's why I'm obsessing about it. Yeah, enterokinase and enteropeptidase. Enterokinase and enteropeptidase. Also, they can tell you brush border enzyme. They can use any of these three words to tell you about the enzyme that converts the trypsinogen into trypsin. So this is the normal, but in case of pancreatitis, this conversion is happening inside of the liver, okay? So the next thing we have is, so a trypsin can move into the circulation. When a trypsin inside of the circulation, it can keep going until it reaches the lung. When it reaches the lung, it can lead to adult respiratory distress syndrome. This is totally fatal. We'll speak about it in respiratory, but this is a killer. Also, the patient can get shocked because of the hypotension and renal failure. And why the renal failure? Because in case of shock, what will happen to the perfusion of the kidney? What happens to the perfusion of the kidney in case of shock? Low. So it goes down. When it goes down, the amount of perfusion to the kidney is going down, so we'll get pre-renal azotemia and renal failure. Hypocalcemia, why? Because there will be basically subinification of the calcium on the pancreas, well, surely but slowly, and that will lead to hypocalcemia in the body. Now, chronic pancreatitis. In cases of chronic pancreatitis, obviously, it's a chronic inflammatory condition. The pancreas will become super small and it will have this little whitish dot. Anytime you see the little whitish dot here, this is calcification of the pancreas, and it's a metapneumonic signs of chronic pancreatitis. The major risk factors include alcohol use disorder and genetic predisposition, like, for example, cystic fibrosis. Remember, cystic fibrosis patient had this really serious pancreatic enzyme release problem, yeah? This disease can also be idiopathic. Complications include pancreatic insufficiency and pseudocyst formation, okay? So, pseudocyst, remember, we call it pseudocyst because it has a granulation tissue, not epithelial tissue. Pancreatic insufficiency. Typically, when less than 10% pancreatic function. So guys, in case of chronic pancreatitis, it's not like boom, you are dead. It's not acute pancreatitis. In case of chronic pancreatitis, it slowly loses its function. So it's like this. It's like boom, 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 boom. It takes so many years to lose all of its function. So when it becomes less than 10% function, you will start to have serious symptoms like steatorrhea, fat-soluble vitamin deficiency, diabetes mellitus, and add please B12 deficiency due to the absence of the removal of the animal protein from the B12, which is something we'll speak about in the metabolism chapter of biochemistry, in which I'm going to explain for you how the B12 is observed inside of the GIT exactly. I mean, the intrinsic factor play a role, animal protein plays a role, pancreatic enzymes play a role, and also the terminal ileum plays a role. So amylase and lipase may or may not be elevated. Why they are not? It's possible for them not to be elevated. The reason is it's a chronic disease. If it was all destroyed, will it be elevated? The answer is no. It's already dead. You know. Almost always elevated in case of acute pancreatitis, however. So the last disease we are going to speak about is acute adenocarcinoma, and then I will take I will make a small bool asking you if you allow me to explain a couple of more pages. So, pancreatic adenocarcinoma, very aggressive tumor arising from the pancreatic duct. Disorganized glandular structure with cellular infiltration. Okay, so this is originating from the glands. As you can see here, there is a huge nuclear to cytoplasmatic ratio. The nuclei are large. And anytime the nucleus is super big in the cell, that means this is a cancer cells because it requires a lot of DNA for division, which means it's cancerous cells. Often metastatic at the presentation, which means that the survival is really, really bad. So it's less than 1 year after the diagnosis. So the tumors are more common in the pancreatic head, which can lead to obstructive jaundice. Will it be painful or painless, the jaundice? Painless. This is the Corvus sign, basically. And I would like to show you a picture of it. If you take a look at this patient. Oh, by the way, guys, since the obstruction, does it happen suddenly or it take time to happen in case of cancer? It takes some time. So the gallbladder, will it be normal or it will start to be enlarged because there will be a backflow of bile? Will it be small or big? Not inflamed. It will not be inflamed. It will be just big. Okay? So this is important. The question is, how big? Big. Really big. So I will show you how big. Just a moment. Okay. Can you see this huge dentation of his abdomen, this thing? This is his gallbladder. It's that big. Okay? It's huge. See? It's this big. Really, really big. Okay. So it's associated with the CA99. How I remember this? Guys, 99, number 9. If you write number 9 like this, it looks like a pancreas. What about 13? 13. 13 looks like a breast. Okay, so this is for breast cancer. What about 125? 125 is for ovary. So I imagine 2 ovaries here and the uterus in the middle. So that's for all 3 CA type of tumor markers. So the risk factors is tobacco smoking is the most important one. Chronic, and they do ask about it a lot. And chronic pancreatitis, especially age more than 20 years old, and diabetes as well. Okay, diabetes as well, and age more than 50. It's more common in the African American and in the Ashkenazi Jews. So please make a note about that. Often present with an abdominal pain radiating to the back. Weight loss is due to malabsorption and anorexia. Okay, so malabsorption and anorexia that lead to weight loss, and also vitamins deficiency. Vitamins deficiency, especially which one? Which vitamins deficiency do we get? Fat soluble vitamin plus the B12. Yes. Okay, so migratory thrombophlebitis can occur, also known as a Trousseau syndrome, not the Trousseau sign. That's totally different. So the migratory thrombophlebitis, it can lead to redness and tenderness due to impalpation of the extremities, and it happens because of hypercoagulable state of the body, because cancer can lead to hypercoagulable state. Okay, so hypercoagulable state will lead to obstruction of the veins, which can precipitate to Trousseau, not sign, but syndrome. So when you take a look at the Trousseau syndrome, you can see that there is a massive thrombophlebitis on the leg. What about Trousseau sign? Where did we see Trousseau sign? So we saw Trousseau sign in cases of hypocalcemia. Hypocalcemia, remember Chvostek sign and the Trousseau sign. The Chvostek sign was on the face, tapping the facial nerve lead to grimace, and the Trousseau sign was like inflating the blood pressure cuff leads to the hand closing. Okay, good. So the last thing, obstructive jaundice with palpable and non-tender gallbladder. So there will be obstructive jaundice, and the gallbladder will be super big, but it will not be tender. This is Courvoisier sign. What can you do for this patient? Not much, actually. You can do Whipple procedure that prolong their life, does not cure them though. Okay, so keep that in mind. You cannot save them. You cannot save their life, but you can prolong it a little bit. So you can prolong it by only 3 to 4 months. Is it worth it? Whipple procedure is really a huge procedure. The how do you say it? Like, to get better after the procedure, you need months actually. So it's not actually worth it. But sometimes we still do it. Why would you like to do such really invasive procedure in someone? Yes, I am recording. Why would you do such an invasive procedure on someone? Pregnancy, absolutely. If she's pregnant, you would like to make sure she delivers before she passes away. Yes? So that's why would you like to earn some time. Okay? So let me just check how many pages did we do today. So 1, 2, 3, 4. Wait, got lost. So again, really quick, just counting. 2, 3, 4, 5 and a half. Okay, so 5 and a half. I wanna finish half more page. Do you allow me, guys, to finish this topic, please? Opening a quick poll. I just need 2 votes. Okay, maybe tomorrow. Okay, no problem. So we'll continue with tomorrow. Today was a productive session, and we will continue tomorrow. So see you guys tomorrow. Bye bye.